Good evening and welcome to all the faculty members and delegates to the HER2 in gastric cancer webinar. Let us begin with our agenda. We have an exciting lined up today. So we have for our first talk, I would like to invite Dr. Shaina Dawood ma'am. She is a consultant and a professor at Mediclinic City Hospital, Dubai, and she's going to speak on elevating patient care, a deep dive into HER2 positive gastric cancer. Over to you, ma'am.
So thank you very much for the invitation. And I'm just going to share my slides. Please let me know if you can actually see my slides. I hope you can see my slides.
We can see, ma'am. Yeah, full screen also. Yeah.
Perfect. Thank you. So I've been asked today to talk about a really very exciting topic, because if there's ever been an explosion after breast cancer and lung cancer, it would be for gastric cancer. And so today we're going to take a deep dive specifically into HER2 positive gastric cancers in that advanced setting. These are my disclosures, and if anyone would like to get in touch with me offline, I would highly encourage you to scan the QR code. Now, let's take a step back and acknowledge that gastric cancer is no longer considered to be a homogeneous disease. It is, in fact, a heterogeneous one. You can see the key features of the TCGA and the ACRG gastric cancer subtypes. You've got the MSI high from the TCGA subtypes, the GS, the EBV, and of course the SIN type. And then, of course, from the ACRG, you've got the MSI high type, and then amongst the MSS, you've got the EMT type, the TP53 mutant, and the TP53 wild type, all having very distinct characteristics. And what you see here on this side of the slide is that the therapeutic landscape of gastric cancers based on their different subtypes can in fact be very, very different. Now, in the community, and I'm a community-based oncologist, in the community, when we're looking at our patients in the clinic, it's important to be able to discern which of the biomarkers are going to help guide therapy. And the ones that we always have to do, irrespective, includes HER2, PD-L1, MMR, EBV, Claudin 18 with zolbetuximab now coming into play. And of course, FGFR-B is also very, very important. What you see here on this slide is that over time, there's been an explosion of data targeting these different biomarkers in that first line setting amongst patients with advanced gastric cancers, from targeting HER2 from the TOGA study, which looked at addition of trastuzumab, all the way to multiple clinical trials that has added immunotherapy in those patients with PD-L1 positive disease. And then, of course, we've got zolbetuximab in patients with Claudin 18.2 disease. And of course, now we've got other biomarkers such as the HER2 low, which are coming into play, but of course, not as yet approved. And here what you see is just a summary of those key clinical trials that has revolutionized the way that we see our patients in that first line setting. You've got the Checkmate 649 trial, which showed that adding nivolumab improves overall survival of patients, and you're adding it to chemotherapy versus chemotherapy. Then you've got the Keynote 811, which we'll be deep diving in a little bit later on, that looked at adding immunotherapy to anti-HER2 therapy in those patients with HER2 positive disease. And then, of course, you've got the Spotlight that looked at adding zolbetuximab to chemotherapy in patients with Claudin positive advanced gastric cancer. And across the board, you are seeing improvement in overall survival. We've never seen that before, but we've always known that biomarker-directed therapy does improve prognostic outcome. Now, what I'm going to do is try and work through a case so we can see the different aspects of actually treating specifically that patient with a HER2 positive advanced gastric cancer. This is a 35-year-old gentleman who actually is from my facility, works as a nurse. He presented with significant abdominal pain and had a CT scan that showed a gastric mass with extensive liver metastases. Biopsy showed that he had an adenocarcinoma in keeping with a gastric primary. Now, I think one of the first questions that we need to ask ourselves, should we be profiling this tumor? And I can tell you right off the bat, the simple answer is yes, because you need to know all those biomarkers to be able to individualize therapeutic plan. Now, when you're looking at, I've already talked about the different subtypes. You've got MSI high, you've got SIN, you've got GS, you've got the EBV positive subtypes of gastric cancer, and specifically when you're looking at HER2 positive gastric cancers, you can see approximately 12 to 20% of these patients are going to have HER2 positive not breast cancer, but gastric cancer, which primarily lies within that SIN subtype, which constitutes about 50% of all your gastric cancer subtypes. Now, the probability of having a HER2 positive gastric cancer really depends on which type and where it is in that GI pathway. So those patients who've got actual tumors in the stomach itself is about 12 to 20%. Those in the GEJ junction, it's about 32%, so slightly higher. If you've got an intestinal type, it's about 30%. And of course, if you've got a diffuse type of gastric cancer, it's about 5%. Now, in my particular patient, we did send the tissue off for molecular profiling, and you can see it's HER2 3 plus that was actually also amplified, making this patient a candidate for anti-HER2 therapy. In addition, this patient actually has PD-L1 positive disease, which I'm going to show later on. And you can see all the different biomarkers that were also tested in this particular patient. So now one of the questions that's commonly asked, and that's why when I say HER2, I think about breast cancer, but now we need to also think about gastric cancer. But there are challenges. It's not as straightforward as testing in breast cancer because now we're more in tune with it. So one of the questions that repeatedly comes up, what are the challenges when testing for HER2 within the realm of gastric cancer? So gastric cancer is not the same as breast cancer. There's a lot of spatial heterogeneity, where you can see you get intratumoral HER2 heterogeneity in these patients, where within the same tumor you can see a part that's negative and a part that's positive. A lot of these patients also have concurrent other genomic alterations that are targetable. You have to think about that. You can see that also there's intra-patient HER2 heterogeneity, where the primary may be negative, but the metastatic lesion may be positive, and so you should always be testing both samples. You can see there's also temporal heterogeneity in these patients. So if you subject a patient who's got HER2 positive gastric cancer with anti-HER2 therapy, you've got to be careful that at progression of disease, a lot of these patients tend to lose expression of HER2. So trying and attempting to target with an anti-HER2 agent may not necessarily work. Now, remember, my patient's been diagnosed with a stage 4 HER2 positive gastric cancer. So the next question that we ask ourselves, what would be the optimal first-line therapy for this particular patient with a HER2 positive advanced gastric cancer? Well, what set the platform or changed the standard of care was the original TOGA trial that came out almost 2 decades ago. The TOGA study took patients with HER2 positive, either IC3 plus or FISH positive, advanced or metastatic gastric cancer or GEJ junction adenocarcinoma. These were chemo-naive patients in the metastatic setting. They were randomized to get either chemotherapy or chemotherapy plus trastuzumab. The primary endpoint of this trial was overall survival. You can see clear-cut, a very nice separation in the Kaplan-Meier curve, a very early separation in the Kaplan-Meier curves, improving the median overall survival from 11 months to 13.8 months, translating into an almost 30% reduction in the risk of death from disease. And you can see that in terms of progression-free survival, it improved from 5.5 months to 6.7 months. The question then came, although very good, and you can see that overall survival with an anti-HER2 therapy like trastuzumab, 13.8 months. Could we do better than that in the first-line setting in those patients with HER2 positive gastric cancer? Well, there's been a lot of other anti-HER2 agents that have actually been investigated to try and enhance the effectiveness of trastuzumab in patients with gastric cancers. And you can see the Jacob trial tried to look at adding pertuzumab, and this improved the median PFS from 7 months to 8.5 months with no gain, really no significant gain in the overall survival of these patients. You can see the logic study tried to use lapatinib plus capecitabine and oxaliplatin. Again, it wasn't significant in terms of overall survival advantage. And so then the question came, Could we take immunotherapy that we know works in this HER2 negative cohort of patients? I showed you the results of the CheckMate trial. We can see a very nice overall survival when you added Nivo to patients who had a gastric or advanced gastric cancers. And you can see that there was an overall survival advantage. So could we potentially use immunotherapy in these patients who have HER2 positive gastric cancers? And you can see we had a lot of evidence that actually showed that HER2 status correlates with PD-L1 positivity. So the more the patient has a HER2 positive status going from 0 to 3 plus, you can see the PD-L1 positive, the percentage of PD-L1 positive cases actually does increase. You can see SYN tumors tend to be immune excluded. And you can see that over here, these SID tumors tend to be immune excluded, but the EBV and MSI high tumors are obviously very immune hot type tumors. But you can also see some preclinical evidence where when you're combining anti-HER2 therapy, that means you're inhibiting the HER2 pathway as well as inhibiting immune pathway, you can actually think about potential synergy between anti-HER2 therapy as well as immune checkpoint inhibitors. So we had a number of different studies that actually looked at this. You've got the MSKCC trial that looked at trastuzumab, pembrolizumab in combination with chemotherapy. You can see an overall response rate of 91% with a median progression-free survival of 13 months. You can see the Pantera trial, which looked at trastuzumab, pembro plus chemo, and you can see an overall response rate of 76%. And then you've got the NEHI study, which looked at nivo plus trastuzumab plus oxaliplatin and an overall response rate of 83%. So again, that set the stage for the Keynote 811 trial, which was a phase 3 clinical trial. These were chemo-naive patients, HER2 positive, who had advanced gastric cancers, randomized to get trastuzumab plus chemo or placebo plus trastuzumab plus chemo. And you can see there was a co-primary endpoint of progression-free survival as well as overall survival. In the first interim analysis, they confirmed an overall response rate of 74.4% when you gave pembrolizumab plus trastuzumab plus chemotherapy versus 51.9%. And this was what led to the initial FDA provisional approval that allowed us to actually take it into the clinic very, very quickly. At the third interim analysis, you can see in terms of overall survival and progression-free survival, clear-cut advantage. You are now getting an overall survival of 20 months with the addition of pembrolizumab. But the caveat was it was specifically in patients with PD-L1 positive disease. It did not add any benefit in those patients with PD-L1 negative disease. And this was the history of the FDA approval. FDA first granted an accelerated approval in May 2021 based on the overall response rate of Keynote 811. Then they amended the approval in 2023, restricting it to those patients with a CPS score of more than 1, and then gave a final approval in March 2025, allowing all patients who could fit the eligibility criteria with a CPS of more than 1 to get pembro plus trastuzumab plus chemotherapy. Now, can HER2 testing results impact prognostic outcome? I thought this was a very, very important question that's been asked several times, because if you don't get it right, your patient will not do well. And this is more so in patients with gastric cancer. And you can see the difference between gastric cancer and breast cancer in terms of looking at the membranous distribution of the antibody is generally incomplete in gastric cancer, but predominantly circumferential. In breast cancer, you can see intratumoral heterogeneity is commonly occurring in gastric cancer, more rarely seen in breast cancer. And the HER2 expression and anatomic location, there's a variation which is more frequent in proximal stomach, while that variation doesn't actually occur in breast cancer. But this was the study that really changed it for me, because it made me think that we really need to be very cautious in our testing. And that was the variant study. The variant study was actually a prospective multi-center study that took place in Europe, in which patients with metastatic gastric cancer were prospectively recruited at 35 German sites and followed for about 48 months. And the HER2 status was centrally assessed by immunohistochemistry and SISH. In addition, it was also the HER2 gene expression was assessed by qPCR. And what they essentially found was a high deviation rate of 22.7% between central and local testing. interestingly, they found that the patients who did the best were those patients who had a central HER2 positive and a local HER2 positive, while those patients who had central HER2 positive and local HER2 negative also did very well, but this was a very small group of patients. But those patients that were HER2 positive, but local HER2 positive, but central HER2 negative, and those that were also double negative did very badly. So again, telling then this was something that my pathologists were very interested in terms of calculating the optimized HER2 threshold for prediction of overall survival. And what you essentially see in terms of overall survival, when you're looking at the HER2 staining, it's that 40% cutoff, which tells you that these are the patients who are going to be doing very well versus those that are not going to do very well. And then, of course, you've got the amplification ratio slightly different from what we see in breast. A cutoff of 3 was what they decided was what you see in the terms of the differential outcome in terms of overall survival. So in my patient, he was commenced on pembro plus platinum-based chemotherapy plus trastuzumab, did actually very well. He had a disease-free survival of 1 year. Unfortunately, his disease then progressed. The question was what to do next, really begging the question, what are you going to use as your optimal second-line treatment in a patient with HER2 positive disease? Now, we've got a lot of data that supports the use of different types of agents in the second line setting. You've got the REGARD study, which looked at ramucirumab, a single agent, where it improved median progression-free survival from 1.3 months to 2.1 months, with a gain of overall survival of 1.4 months. You had the Rainbow trial that looked at the combination of ramucirumab and paclitaxel versus paclitaxel. Here, the gain in overall survival was 2.2 months. And then, of course, you've got the Keynote 061 that looked at single agent pembrolizumab. Here, there was an improvement in PFS, but not really in terms of overall survival. So the question is, are any of these trials actually applicable in a patient who's actually received pembrolizumab plus trastuzumab plus chemotherapy? And the simple answer is no, it is not applicable. When you're looking at key guidelines for the third line setting, you've got the Keynote 059 that looked at pembrolizumab monotherapy. You've got the Attraction 2 that looked at nivolumab. Again, something that we use in patients who have not received immunotherapy in that first line setting. And then, of course, you've got oral trifuldenine, which again was something that's also there in the third line setting, but all very, very abysmal results. So then the question is, could we treat these patients like we do in breast cancer and actually use anti-HER2 therapy beyond progression of disease? And that's actually been looked at in the T-ACT study, which looked at trastuzumab plus paclitaxel after patients had used trastuzumab in the first line setting, the Gatsby study that looked at TDM1 versus taxane, and the Titan trial that looked at lapatinib plus paclitaxel. I can tell you there was lack of activity across the 3 trials, and probably this lack of activity, remember I told you that when you give anti-HER2 therapy to these patients in the first line setting, you get about 29 to 69% of these patients will actually lose HER2 expression. And probably this loss of HER2 expression is what is driving the lack of benefit in terms of using agents like trastuzumab or pertuzumab or TDM1, which is what we also see in breast cancer as well. So, and we also know that with every line of therapy that we're using in gastric cancers, the median overall survival reduces significantly, making really abysmal results. So we really needed something else. We needed something like an antibody drug conjugate in the form of trastuzumab deruxtecan that had already proved itself in the HER2 positive realm in patients with breast cancer. And you all know about the key attributes of TDXD. The biggest attribute is it's got a better payload, high potency of the payload, a high drug to antibody ratio, and it's got that bystander effect that makes it applicable even in those patients that probably have lost that HER2 expression. So here we have, and this set the stage for the Destiny Gastric 01 study that actually was the reason why this agent was FDA approved in this realm. It took patients who had progressed, who are HER2 positive gastric cancer patients, who had progressed on at least 2 prior lines of therapy that had to include fluoropyrimidine and a platinum agent. These patients had to have HER2 positive disease. And in the primary cohort with HER2 positive disease, they were randomized to get either TDXD. This is a higher dose here that you're seeing at 6.4 milligrams per kg versus physician choice of chemotherapy. This was a phase 2 randomized clinical trial. They also had an exploratory cohort that we'll be talking about later on that looked at these patients with HER2 low disease. But this is the cohort that I want to focus on because these were the patients that had progressed actually on first-line anti-HER2 therapy. You can see the median therapy of prior lines of therapy was actually 2 here. You can see in terms of the baseline characteristics, almost 80% of these patients were IC3 plus, with FISH positive disease with IC2 plus being about 20% of these patients. Now you can see in terms of overall response rate, it improved from 14 months to 51%, 14% to 51%. The median overall survival improved from 8.9 months to 12.5 months. And remember, this is second line and beyond. And the median progression-free survival improved from 3.5 months to 5.6 months, with both the IC3 plus and the ISH positive patients actually benefiting. But the biggest benefits really seen in that IC3 group of patients, telling us that TDXD was now the set standard for these HER2 positive patients who had progressed on first-line anti-HER2 therapy in second line and beyond, where it was improving both overall as well as progression-free survival. We then saw the Destiny Gastric 02 trial, another phase 2 study, which it was a single arm study that looked at TDXD, similar cohort, overall response rate 42%, median progression-free survival 5.6 months, and a median overall survival 12.1 months, reaffirming the data that we saw in the Gastric 01 trial. Now, could we take it earlier into the earlier line setting in that in that second line, so not second line and beyond, but really that true second line setting? Well, this was the Destiny Gastric 04 trial. We just saw the results presented at ASCO a couple of weeks ago. These were patients HER2 positive who had centrally as well or locally confirmed HER2 positive disease on a recent biopsy. This is very important. These were patients who had progressed on trastuzumab, and they all had a recent biopsy that confirmed HER2 positive status. These patients were randomized to get TDXD or the standard of care. I showed you that data, the Rainbow study, the standard of care, which would have been ramucirumab plus paclitaxel. The primary endpoint of this trial was overall survival. You can see from the baseline characteristics, two things I'd like to point out. Almost 85% of patients had IC3 plus disease. But look at this. You can see that only about 15% of patients had prior immune checkpoint inhibitor. And we know that the Keynote 811, the majority of these patients will now be having pembrolizumab plus trastuzumab in that first line setting. And that is something that you need to think about. Interestingly, when you looked at subsequent anti-cancer therapy in these patients, you can see in the ramucirumab paclitaxel arm, only about 20% of patients actually went on to receive trastuzumab deruxtecan. About 5% went on to receive dasatimab vedotin, which is another ADC that these patients were actually they're actually being explored in that line setting. Overall survival, primary endpoint, it improved from almost 11.4 months to almost 14.7 months with TDXD, translating into a 30% reduction in the risk of death from disease. So again, very early separation in the Kaplan-Meier curve. This is what I like about this. There's no drop-off where you see these Kaplan-Meier curves being together and then they're separating. Here you're seeing a very, very early separation in the Kaplan-Meier curves, telling us the benefit is actually very early on when you're comparing it to ramucirumab and paclitaxel, with almost every subgroup of patient, irrespective of where the patients are coming from, actually benefiting, even in the patients who received primary immune checkpoint inhibitors versus those who had not received a checkpoint inhibitor. When you're looking at PFS, again, a nice improvement in the PFS. You can see almost a 26% reduction in the risk of progression of a disease. Again, statistically significant. In terms of overall response, you can see that the response rate improved from 29% to almost 44%. And you can see the duration of response improved from 5.3 months to 7.4 months. When you're looking at the drug-related events, I think this was important because obviously TDXD, higher dose than what we're used to in breast cancer realm, you can see similar to what we're seeing with TDXD. There's more fatigue, there's more neutropenia, there's a little bit more nausea, and the rest of it is very, very similar to what we tend to see with TDXD. This is important in terms of interstitial lung disease, a higher rate of interstitial lung disease, 15% of patients getting ILD, but mainly grade 1, grade 2 ILD, very few or no patients actually getting the grade 4, grade 5 ILD. So these were some of the questions I asked myself post Destiny Gastric 04. Is Destiny Gastric 04 practice changing? Yes, it firmly established TDXD in that second line setting. And I've seen a lot of people in the community after Gastric 01 actually using TDXD in the third and fourth line setting. It shouldn't. It should be used straight after first line treatment. But the question then comes with the Keynote 811 now being the standard of care in that first line setting, how will this impact efficacy results? And we do realize that when you're giving pembrolizumab plus trastuzumab plus chemotherapy, you may actually be losing a lot more HER2 expression. I deliberately put this image up here. This was a discussion that took place after the presentation of the results of the Gastric 04 trial, in which the discussant actually said the prolonged PFS with this regimen could result in a higher HER2 loss at progression, potentially reducing the TDXD efficacy in the second line setting. But for me, the protocol actually mandated that you biopsy these patients at progression. So again, I'm not sure that that is an actual valid point. What could be valid is that we just don't know what is the likelihood of efficacy post-immunotherapy. I think it should be almost what we're seeing, if not better. We are also seeing higher rates of ILD compared to breast cancer. This is probably dose-related, although not grade 3, grade 4. And how will the results of the Gastric 05 and other first line trials impact the second line results? I think what's probably going to happen is we're going to take TDXD into that first line setting. We've also got some other important trials that are going to come up, but for the time being, it's the second line setting where TDXD is now firmly established. Irrespective, on Monday in the clinic, I will offer TDXD to my patients in that second line setting. And that's exactly what I did for this particular patient at progression of disease. We did a biopsy. It confirmed HER2 3+ status of the tumor. Patient was commenced on TDXD, and this patient had a progression-free survival of 7 months. Interestingly, at progression, this patient now, we biopsied him, and the HER2 is 1+. So the real question is, what are we going to do next? Which takes us into the final question that I'm going to talk about, what to look forward to in the future. Well, one, we know that expression of treatment target from HER2 positive to HER2 expressing gastric cancer is what the future is going to hold, just like in breast cancer, because we have that exploratory analysis from Gastric 01, which you can see here on the screen here, where they took patients with HER2 1+ and HER2 2+-ish negative and gave these patients trastuzumab deruxtecan, and you can see very nice overall response rates, but importantly also some very interesting PFS results, and these were preliminary evidence in a heavily pretreated cohort. We also have to recognize that patients will not only have HER2, they will have probably co-occurrence of oncogenic drivers because of the intratumoral heterogeneity of different aspects. And you can see they can be MET amplified, they can be HER2 amplified within the same patient. You can see different metastatic lesions will have different expression of HER2. You can see in this particular patient, scapular metastases was HER2 negative. Here, the metastases in the liver was HER2 amplified. So again, something that we need to think about. We also have to recognize that we're probably going to have to look at all biomarkers in that first line setting, because not everyone, like I said, has one biomarker, and where to actually put in anti-HER2 therapy versus TDXD versus immunotherapy versus combining everything is going to be a challenge going forward. But that's what Gastric 03, where it's going to be looking at combination strategies with TDXD. It's a very interesting study, phase 1, phase 2 trial that's looking at TDXD in combination with various agents, primarily with immunotherapy and 5FU. You can see some very interesting overall response rates here. In terms of progression-free survival, I found the TDXD, 5FU, CAPE, and Pembro data very interesting, where you have a median progression-free survival of almost 10 months. And when you're looking at the overall survival, it's almost 23 months. So again, very interesting. And then, of course, not to forget, TDXD and trastuzumab are not the only anti-HER2 agents on the horizon. We've got newer anti-HER2 agents that are coming up, such as zanitamab, which is already approved in certain cancers. Here it's being explored in gastroesophageal cancers, and you can see there are a number of ongoing trials for this. And then, of course, you've got margetuximab in combination with pembrolizumab has also shown some results, overall response rate of almost 29%. Again, when the patient's CPS score is more than 1, is an overall response rate of almost 44%. So again, very interesting. And of course, finally, taking these agents into the earlier line setting, we have studies looking at neoadjuvant TDXD, where we've got preliminary evidence of good result of good tumor shrinkage using this, and I know that they're looking at actually combining TDXD with CAPE and durvalumab. This is being planned, and then we've got the Trinity trial that's actually looking at preoperative FLOT, and if the HER2 status is confirmed, they're actually looking at those patients being randomized to either get TDXD plus FP versus FLOT. And again, I think this is going to be very, very interesting because specifically looking at those MRD positive patients post-operatively to see if you can actually clear it. So what are the guidelines? This is what I'm going to end with. What are the guidelines? These are the ESMO guidelines. In the first line setting, you give a platinum-based chemotherapy. If you're HER2 positive, PD-L1 positive, you will add trastuzumab plus an immune checkpoint inhibitor. PD-L1 negative, you're going to just give trastuzumab on its own. In patients with HER2 negative disease, you look at the different biomarkers and you add accordingly. PD-L1 positive, immunotherapy. Claudin positive, you will add zolbetuximab in these patients. In patients who have now progressed to the second line setting and they've actually have HER2 positive disease, TDXD is the standard of care in these patients. And in the third line setting, HER2 positive disease, if they've not received TDXD in that second line, they have the opportunity to use it in the third line. If they have received TDXD in the second line setting, you have other types of chemotherapeutic agents that you could potentially try, although I do think that this is unmet need that we need to be exploring more carefully. So thank you very much.
Thank you so much, ma'am, for such invaluable insights. Now, moving ahead with our agenda, I would like to invite our
Anshika,
moderator.
are there any questions?
Not yet, sir.
No questions from the participants?
No,
Can you
sir.
can you announce to the participants that if they have
Yes.
any questions, they can.
Yeah, I have questions. Hi,
Of
Dr.
course you do,
Saina.
Dr. Ahmed.
That was a wonderful talk, as usual. Okay.
Yes.
So we've seen that wonderful data. I'm curious about two things. Why are we stuck with that 6.4 mg per kg in stomach? And that's the only place we are
I
left with that
know.
dose.
Exactly. And unfortunately, that is the approved dose that we have to use. I know that there's been a number of different studies trying to say, can we de-escalate? And it's the same in lung cancer as well, right? The dose is not the same. And we know that ILD is dose dependent. And personally, it doesn't take me long to de-escalate. I can tell you. I'll start off with the approved dose. I always do. But it doesn't take a lot for me to de-escalate in terms of coming back to the dose that I think is probably more appropriate for patients. But as of now, this is the dose that's being used in gastric cancer, and we just have to stick with it. But again, very low threshold to de-escalate.
Yeah, I fully agree. It's
What do
quite
you do?
frustrating.
What do you do, Dr. Amin?
So we have gone to 5.4 mg per kg all over the body. That's become our standard dose. I think that's been much more uniform and easier.
Yeah,
Another thought
I'm more I tend to use the evidence more, but you're completely right. I don't disagree with you at all.
Yeah. Another thought was this keynote 811. Uh, I kind of, I'm where I'm stuck with. I believe the data. I'm very, very pro that data. I'm just not able to get that high PDL1, that 1% numbers, even in the HER2 population. So what percentage of HER2 positives are you getting PDL1 positive, CPS more than 1? And of course, the other ones which are not in the HER2 positive space, what is that percentage?
Well, I don't know what the exact percentages are, but a lot of these patients, as they're more and more HER2 positive, the percentage of PD-L1 is actually quite high. And I can tell you, I've had a number of HER2 positive patients. A lot of them are PD-L1 positive. So I've used Keynote 811 quite a bit. It's also how you're testing, and I think it's the platform that you're using as well for the testing, because I've seen that when I get it tested within the country itself over here, I tend to get all negative results, but when I send it off to the US, I get proper, so I think it is a question of who is testing it. And I don't think that the percentage is very low. So I do think a good proportion of these patients, because they enroll very quickly as well. So I think a good proportion of these patients will be PD-L1 positive.
Yeah, the data they spoke, they said 85% positivity with HER2 positive PD-L1 positivity.
So
85% is amazing.
I
Yeah,
I can tell you a lot of my patients are positive.
yeah.
That at least for me, a lot of my patients are positive. And what I'm looking at over here in terms of the data that I just presented to you, the 3+ was close to 75%.
Yeah. Okay. That's I think we'll need to just test more and more to get it. At least they should be positive.
Absolutely. I think there's a question here from someone.
Yeah, ma'am. It's a question from Jayati Tripathi. Ma'am, if in starting itself, I mean at the start, patient is HER2 2 or 2 plus or 1 plus, do we
Yeah,
give
okay.
anti-HER2 to such patients? That's the question.
Simple answer is no. Anti-HER2 therapy, trastuzumab or pertuzumab or TDM1 does not work in these patients. It's been repeatedly shown. The interesting question is, will TDXD work in these patients? It's currently being explored. I just showed you the data from the Gastric 01 trial that actually looked at HER2 low. It's trying to expand the cohort of patients that could potentially benefit from TDXD, but you do not start with anti-HER2 therapy in patients either 2 plus ish negative or 1 plus. What you do is you do the PD-L1 testing and you give them immunotherapy. And if PD-L1 is negative, of course, you have to test for Claudin as well.
Absolutely. Thank you so much, ma'am, for that. Let us check if there are any more questions. Darshan, Anshika, any more questions from the participants?
1 minute, sir. No, sir.
No more questions? Can you
No.
please just announce to the participants that this is a chance to ask questions to
Okay.
chime in?
Audience can ask their question by clicking on Ask Question button on their screens. So please.
I
Let's
probably talked too much and put everyone to sleep.
probably, ma'am, it's the other way around. I think you cleared all their doubts even before they appeared. It was such a wonderful
No.
talk. Maybe let's give it a minute, and if there
Sir,
is
one question.
Okay.
We have one question, yeah. So the incident is higher because of the site GEJ versus pylorus.
So, I mean, HER2 positivity is definitely higher depending on the site. And maybe, Dr. Amit, maybe you can come back online so I can see you. Maybe the types of patients that you're seeing is in India, who are you seeing more? Gastric, pylorus, or the fundus, or is it G junction tumors that you're seeing more of? Because he's right.
Yeah. I think the numbers of GE have gone up quite a lot in the last few years. I've seen more and more GEs. There's no doubt about that. And GEs, we keep obsessing about HER2 and going and testing and testing. That's the way with HER2 has been. HER2 has been pretty good. It's the PDL1 which has always been my worry.
Okay, yeah. And then there's another question. Do you go ahead with Claudin 18.2 IC in only HER2 negative cases? No, and when I send for testing, I test for everything at the same time. I do not do sequential testing. Number one, it drives me bananas to do sequential testing for anybody. I like to do comprehensive testing. Plus, it's important that you get all the information back in a timely fashion. So it's important to do that HER2 testing, the Claudin, the PD-L1, it all gets done together. The question that you're probably trying to ask is that if it's HER2 positive and Claudin 18 positive, what will you target? I think that's the question you're trying to ask. So should we do it only for HER2 negative? Well, HER2 positive, you always target the HER2 positive pathway. HER2 negative, you look at the other targets like Claudin, and you target the Claudin there. But there's a lot of interesting trials going forward that's going to look at combination strategies that's going to really open up. Is please elaborate temporal heterogeneity of gastric carcinomas a bit. And I think I explained that as you treat these patients, they tend to lose their HER2 status when you're giving them anti-HER2 therapy over time. And I've seen it. I mean, I just showed you a case where it happened after I treated with TDXD. So it's important, more so than in breast cancer, it's important to actually biopsy at different time points at progression of disease and actually get that information. And as TDXD will be used in broader cohorts of patients where you're looking at that HER2 low expression as well, again, that'll be very, very important. Then someone said, I missed earlier slides. Just curious, what percentage of gastric cancer patients are HER2 positive, and what percent are going to get benefit from suggested line of therapy? So you have, depending on the site, it can be anywhere from about 12% all the way to 30% of your patients, depending on the site, for HER2 positivity. So all these patients should be offered first line therapy with an anti-HER2. If there's CPS more than one, as Dr. Ahmed said, which should constitute about 75% of your HER2 positive patients, you should be offering immunotherapy plus anti-HER2 therapy plus chemotherapy. Upon progression of disease, biopsy, make sure it is still HER2 positive, and then offer TDXD. Have you adopted this in clinical practice, Dr. Ahmed?
So we are insisting on the biopsy many a times, but I still believe if my patient did very well on trastuzumab chemo and then progressed after a long time, I still believe they are HER2 driven, and I'm okay to go even without a biopsy. Anyone with that rapid
You're
progression,
brave.
I'm not convinced. I'm not convinced about them. Then it becomes important to
Okay.
biopsy. Are you
Okay.
doing your FGFR testing now by
Yes,
IHC? Have you added that again?
it comes automatically. So I send all the tissue to a lab in the US. They do all my IHCs for me as well as the DNA, RNA on it. So it gets comprehensively put in the report, which is what I like. I like all the information to be able to tease out how I'm going to appropriately treat the patient. So yes, we do it comprehensively. And it also prevents tissue wastage. You know, when you do these sequential testing, it always prevents tissue wastage.
No, absolutely, absolutely.
All right. So I'll let you get back to your panel discussion. It was an honor to be here and actually talk to you about, especially the Gastric 04 trial that was presented at ASCO. Truly practice changing. What I like about the trial, clean, neat, asked a specific question, and asked specifically this whole thing about the heterogeneity of gastric cancer, saying biopsy, test for HER2, and now you got a clean cohort. So even that ambiguity that you might have lost HER2 expression in some of those patients was not there in the study. So I think, thank you so much for allowing me to discuss this. And I hope to see you guys soon.
Thank you so much, ma'am. It was, I mean, a very enjoyable talk, and I am sure everyone enjoyed a lot. And thank you so much for answering all the questions so comprehensively, taking time out of your busy schedule. We really appreciate you being here, ma'am. Thank you so
Anytime.
much.
Thank you so
Thank
much, ma'am, for
you. Take
joining.
care. Take care. Bye. Bye. Bye.
So, moving on with our agenda, I would like to invite Dr. Amit Ratan sir as a moderator. He is an HOD and consultant in the Department of Medical Oncology, Immunotherapy, Precision Medicine at Manipal Hospital in Bangalore. Our panel discussion is on HER2 in focus, testing and interpretation for superior gastric cancer outcomes. I would like to invite our panelists Dr. Jayati Datta, Dr. Sunita Semlati, Dr. Anuradha Sikran, Dr. Vidya MN. Over to you, sir.
Okay. Thank you very much, AstraZeneca. Good evening, everyone. Um, I didn't know I was the odd man out. I'm in between all the pathology teams. I actually thought there were a mix of pathologists and clinicians, and I thought we'd put in the questions asking clinicians and pathologists and do it, but I think it'll end up going up. I'm the only clinician, and we are all pathology. The rest of everyone is pathology. So you can we can see how it goes. Okay, right. So let's put in the slides. 1 minute. I will just share this. Okay, I think the slides are visible.
Yeah, they are visible. Hi,
Okay.
hi, Dr. Amit. Hi.
Yeah, hi.
Hello.
So, Shahina actually covered everything very nicely, and she gave her perspective about the whole aspect of HER2. For clinician point of view, for us, when we see gastric cancer, we say in the metastatic setting, we talk about 12 to 20% are HER2 overexpressed, and when we look at which types, it is mostly the intestinal types. If you look at pathology type, 30% of intestinal types. If you look at diffuse, it is much lesser. If you look at GE junction, that's where you get the maximum amplification over expression, 33% of patients. And that's why we always say when we see GE junction, we keep chasing the HER2 much more whenever we try to look at which patient we want to. Uh, so let's quickly discuss uh, experiences. Basically, everyone's testing for HER2, but let's quickly discuss experiences. Dr. Jayati, if I can come to you, HER2 testing for you in stomach in your centers, what has been the percentage and what has been the type depending on histology and location?
Yeah, thank you and good evening, sir. Am I audible?
Yes.
Oh, all our gastric biopsies bearing cancer are upfront tested for HER2 um, in the endoscopic biopsy itself. In the endoscopic biopsy, as you said, the tumors with intestinal morphology are more commonly expressing HER2, and the diffuse type, the signet ring cell type, the mucinous type are usually negative. And yes, the G junction tumor and the tumor in the upper part of the body are more commonly expressing HER2. And we repeat the HER2 testing in the resection specimen, particularly if there is a heterogeneity in the tumor morphology. That is some part showing moderately differentiated carcinoma with an intestinal morphology and some part is going PD. We select the blocks with lower grade morphology and repeat the HER2 test on that.
Right. Okay. That's interesting. That's an important part of picking up in heterogeneity. Dr. Anuradha, if I can come to you, do you also do this that you test the biopsy block first, and then when the surgery gets done and the sample comes to you, then again you test it from the
No,
histopathology?
I don't think we test all gastric cancers for HER2. Only when the clinician gives us information that he's thinking of a locally advanced disease or there is some indication to start the targeted therapy, then only we do this reflex HER2 testing. Otherwise, we have initiated reflex MSI testing for gastric cases, but we don't do reflex HER2 for gastric biopsies. And when we HER2 on the gastric biopsies, but once I do on gastric biopsy, I don't repeat on a resected specimen if I get, unless there is a need to do further testing.
Okay, right. And what percentage are you finding the positivity in that sense?
Positivity is around 15% or so, I should say.
Right. Okay, right. Oh, great. Dr. Sunita, if I can come to you, what percentage are you finding positivity in HER2, and what kind of do you do these retestings because heterogeneity is so much? Are you seeing this heterogeneity?
Yes, like we do upfront all biopsies will go for HER2 testing. It is not reflexed, but all of our medical oncologists ask for it for HER2 testing whenever the biopsy is positive for the cancer. The same experiences like whenever there is the intestinal type, it is most probably positive. We repeat the test only when we find the first biopsy negative and we find the intestinal type tumor in the resection specimen. But usually, if it is positive first in first go, and the resection specimen is having the poorly differentiated, we don't repeat the test.
Right. Okay. So well differentiated. You do repeat sometimes, and okay. Great. Moving forward, Dr. Vidya, if I can come to you, how so this is a basic thing that for clinicians it's very important. You have to keep telling them always, how is your biopsy for gastric cancer, HER2 reporting different from the in every aspect from breast cancer? And because that's something that clinicians always attuned to the breast cancer HER2 testing. Gastric cancer came up later, and all of them are though they say it's different, but everyone's not really too bothered to get into what is different too much.
Yes. So once the breast cancer scoring came into picture, the next scoring that we had was predominantly for gastric cancer. The big question was why? Why was the shift being there between the two? That is because we know that gastric cancers are gland-forming tumors, unlike the breast cancers. So this is one thing that we need to keep in to consideration. And also the gastric scoring, it basically addressed the tumor heterogeneity, which is more than that we find in breast cancer. And the second thing is, since these are gland forming tumors, there's going to be incomplete staining. There's not going to be complete staining as we see in breast cancer. So this was taken into account when they brought in the classification and the scoring pattern for gastric cancers. And also if you see, since they're gland forming tumors, basolateral type of staining is very predominant in the gastric cancers, which is very, very unlikely that we see in breast cancers. So breast cancers, these are often called as either 1 plus or 2 plus. That is where we leave it. But a strong basolateral type of staining in gastric cancer is considered as a 3 plus, provided it is like a contiguous cluster of 5 cells in a small biopsy or more than 10% of the tissue in the resection specimens. So having all this into taking all this into account, the gastric classification or the scoring for HER2 came into picture. And this is what every clinician needs to know. And they should also understand that their pathologist is following the gastric cancer reporting for either GE junction or for the stomach biopsy. So this is very, very important.
Right. Okay. That's great. Thank you for that, for kind of telling us the difference between the breast cancer and the gastric cancer scoring. There was a question of what is the minimum number of biopsy cores required to confidently rule out uh, overexpression in gastric cancer, and also the difference between the biopsy sample and the histopathology sample after surgery. Dr. Sunita, if you can take that for us.
Yeah, for the biopsies, because of the heterogeneity of the gastric cancers, usually in the breast cancer, if you have a 1 or 2 core, it is sufficient for HER2 testing. But in the gastric carcinoma, we prefer 5 to 8 biopsy pieces. And it is like no, in when there is necrotic area, one should avoid it. And from the viable area, if they could take it, that will be useful for the HER2 testing.
Okay.
For gastrectomy specimen, there is like you can choose your own place where there is a viable tumor.
Right. In metastatic disease, what happens is for us as clinicians, uh, there'll only be one quick biopsy from the, we would have referred it to the endoscopy and they would quickly do one biopsy. And I think this information is important for a clinician point of view, that as clinicians, we have to tell our gastro, while doing the endoscopy, they need to take enough course, avoid the necrotic areas, give enough course for this, because otherwise we would be missing out on this. It always is a worry for us. Sometimes when we have a lot of G junctions, we don't get enough HER2s. We keep saying, have we missed some? And the way the whole course is changing, it becomes very important.
Dr. Amrit,
Yes,
can I
please.
ask one question? So, are you recommending reflex testing for HER2 on all gastric endoscopic biopsies without the knowledge of whether they are advanced, locally advanced, or metastatic? Do you recommend doing it?
So we are doing it in our center. So our whole thought was the whole way the concepts of oncology changing. We started from metastatic disease, but we slowly start moving on to locally advanced, and then we move off to the in the adjuvant setting. Though in gastric we don't have any adjuvant data at all, but I kind of believe the biology will be important to understand, and getting that information makes sense to me. So that's the reason why in our center we tend to say better to do it and get that information. Yes, for you will only use it in the metastatic setting and not in the other settings, but we'll probably know what percentage of patients overall are HER2 positive even in the early stage versus late stage. So that's why in my center we kind of have started off reflex to do apart from the MSI to always apart from the MMR to always do the HER2 also.
Okay.
Can I just add a point to
Yes.
what Dr. Amit is telling? So we do reflex testing for all gastric cancers. So that includes MMR, PDL1, HER2 neu, as well as Claudin. I think FGFR we are yet to start. So that is the only thing pending from our end. And I don't think we are planning to add on EBV testing. So since it is not so important in our setting.
Yeah, for metastatic setting, we'll definitely, these four become very important for all metastatic patients.
No, I agree that it's for metastatic,
Yeah,
but
no, early
one
stage we are doing
person,
HER2.
yeah,
Agreed. HER2 we are doing for early stage, and MMR we are doing for early stage. This
yes.
has become kind of something we have added on because we want to know what the kind of incidence is and what the it my belief is, because once you take that as a driver, your concepts will change after some time. And it will happen. We've learned it from breast, we've learned it from other issues. So I think with time things will change.
Yeah, I kind of agree. Once the tumor is HER2 driven, it kind of supersedes all other pathway. So it's important to know HER2 to predict the biology of the disease as well.
Yeah, I fully agree. It's just that anyone who says no, I want to save resources and say I will do HER2 only for metastatic because that's where you have a treatment for it. I think that's also perfectly correct. There's nothing wrong in that because that's where metastatic is the place where you can do things, and the guidelines also say that. It's just that all of us are expanding a little more, learning about biology, doing that, getting the information, and that's the way we move forward with this. There
Sir,
was
are you doing reflex Claudin 18 as well?
in metastatic setting we are doing, not in the early stage.
Not in
In
the early stage.
metastatic, all four come, we put all four together and we try to get everything together in one go.
In our part of the country, at least in Kolkata and the eastern part of the country, we have just started getting requests for Claudin 18. So right now we are in the process of standardizing the antibody and all, but
Right,
it is
right.
not.
Yeah. Yeah. So Claudine, because we don't have the drug yet in India, but we all believe the
Mm.
drug will come by maybe by end of this year or early next year. So I
Yeah.
think everyone wants to be prepared and get the information ready. Another very interesting part was always this is what we hear, uh, the HER2 positivity, heterogeneity between the uh, primary site and the metastatic site, or sometimes between the primary and the nodal site. And this always for clinicians becomes a problem because we can't ask, as clinicians, we don't go asking HER2 for everything. We say do one HER2 and that's negative, negative, and we start talking to patients and start treatment. What are your thoughts on this, Dr. Anuradha? If you can take this, how will this kind of reflect into clinical usage? What should we test as clinicians? What should we ask for? Where should we do the HER2?
Supposing we only have the primary biopsy in hand and we don't have any biopsy from a metastatic site, obviously we'll do HER2 only on the primary. But supposing we are already having, say, omental mets or liver deposits, it's better that you do on the metastatic was the earlier thought, but now we are seeing that sometimes it's positive in the primary and negative in the metastatic. So when you have both, it's better to do HER2 on both the primary and the metastatic if you have the biopsies at the same point of time. If you do not have at the same point of time and you have already done a HER2 and you have reported as positive or negative, and sometime down the line patient develops mets, it's better that you repeat there, because I have seen one case where a HER2 positive was negative in the metastatic side, and another case where it was negative initially but positive later.
Yeah.
So from that time onwards, we have decided that if there's a metastatic tumor, we repeat HER2, irrespective of whether it was done on the primary side. So we
Okay.
repeat
So
HER2 on the metastatic side as well.
right. So temporal, I understand. Temporal, straightforward. When we have a progression later, we always test HER2. We do a biopsy repeat and do a HER2, and that's absolutely fine. But what you're telling is spatial. So you would do a primary HER2 and a metastatic HER2
Yes.
if you have both the biopsies.
Have both at the same time, because there's so many studies which have shown that there
Yeah,
is
that's good.
a discordance. So when you are having both together, it is better that you report on both. Just like the NETs, if you have neuroendocrine tumors, there you advise to do KI on the metastatic side because you have a higher grade. But here it's totally different because of the heterogenic nature. You might have negative HER2 in the primary but positive in the metastatic side, and that's what is the information you need to have a positive HER2 for starting the therapy. So that's the policy we are following.
That's good. That's actually a very good thought. I've not been doing this, that doing both on the primary and the metastatic. That's something that we may also have to change, that if we have both biopsies, send both. Dr. Sunita, in your center, you are doing this, and have you seen this change between both the sides?
No, no. I've not seen that. I agree with Dr. Anuradha, but whenever there is a metastatic setup, whatever is most accessible and what is convenient for the clinicians, they do that biopsy, and we do HER2 on that. But I haven't got two biopsies at a time to get the HER2 done. They don't ask for it.
Right, right. I think as clinicians, if we don't ask, then it's not going to be there. And I think we will have to make a change. And looking at these kind of data sets, I think I will definitely start making a change, because you don't want to miss any of those HER2s.
Right.
Okay, I think this is what Dr. Anuradha did answer. And let's move to this. Temporal heterogeneity. This I think everyone has seen. This is something that uh, uh, with treatment, without treatment, all of us have seen this quite a lot. Dr. Jayati, a quick word on your experience with temporal heterogeneity from positive, negative, negative to positive. What has been your experience?
Loss of HER2 expression on metastatic site after trastuzumab therapy is a very common phenomenon. And it is not, I have faced a situation where the clinician asked about whether my test was right, whether there was any pre-analytical factor. So I had to give him the reference that it is a known phenomena. It's a known biologic phenomena for the cancer to lose HER2 expression. And we must be aware of that.
Absolutely. I think this is a learning from the stomach plus. This has always changed. In breast, though we test and say, but in breast we always say once HER2 3+ is always 3+. Though even if you lose it, you will end up treating the same way. But in stomach we can't do that. And as clinicians, that's something that all of us have changed practice and say that no, you always biopsy and test again, except in the rare situation when you cannot and you have to take some clinical decision. Uh, Another another question, I think I should take this up with all of you. I have 4 acclaimed pathologists from all over India. I want to know your PDL1 positive in metastatic stomach, and also your PDL1 positive in HER2 positive metastatic stomach. Start off, Dr. Anuradha, from you.
Yeah, so PDL1 positivity, the exact percentage in correlation with HER2, I honestly am not done to answer this question as to what could be the exact percentage in those who are HER2 positive and PDL1 positive. I think if I'm not wrong, I've had about 5 to 10% of cases where they are co-expression of PDL1 positivity and HER2 positivity.
Okay. And in general, what is your PDL1 positivity in metastatic stomach cancer if I say CPS more than 1?
It's around 8 to 10%.
8 to 10. That's okay. That's number is something. Yeah, I think that's. Let me hear from everyone. I think that'll be
Yeah.
interesting. Dr. Sunita, what's your number?
Yes, I've just not calculated it, but I agree with Dr. Anuradha, like it might be around 8 to 10% only.
This is
But
PDL1
we
CPS
see,
more than 1.
yeah, CPS more than one.
Okay,
And
Jyoti?
we see, but HER2 positive cases with PDL1 positivity, we have seen, so I don't know exactly, that is what we have not calculated it. We might
Yeah. Okay.
do the
Okay.
study.
Right. Dr. Jyoti, your numbers PDL1 CPS more than 1. No,
Yeah,
irrespective of HER2. I'm not interested in HER2. Just the CPS of 1.
yes. My experience is HER2 3+ cases tend to be PDL1 positive with CPS more than 1. So my 8 to 10% of gastric cancers in my setup also have CPS more than 1, and they tend to be HER2 positive in most of the cases.
So no, I'm disregarding the HER2. When they're HER2 negative, how much is CPS
Actually, if you
PDL1?
take is gastroesophageal, esophageal, and gastric, I think it's slightly more. I've not just separated into pure stomach. So
Right.
otherwise, I think the percentage is slightly higher when you combine these three areas.
Right. Right. Vidya, your this thing.
It's around 12 to 15% will be our CPS more than 1. That is GEJ and gastric cancers together.
Yeah, so that's kind of very uniform data I'm getting all over India. My whole contention is this: for us in stomach, the recent guidelines for us immunotherapy as first line for metastatic was approved irrespective of CPS PDL1. So we were not bothered as clinicians. We said, we'll give it to everyone. It's okay. Whatever CPS you give, higher the better. The number is good. If it's even zero, I don't bother. Or if it's even, as long as, it doesn't matter. But recently, the FDA gave a withdrawal of both the immunotherapy drugs for CPS less than 1. Both Nivo and Pembro was now withdrawn and said you cannot use it if your CPS is less than 1. And now we are in soup because the Western data says stomach CPS more than 1 is 60%, and HER2 positive CPS more than 1 PDL1 together is 85%. Their data is that in the Western, 60% PDL1. And I'm struggling because now I have lost 50% of my patients. I can't give them. So it's very surprising. I keep thinking, is it our biology is different, our tumors are different, or is it different because our techniques are different? You keep thinking both ways.
I think our tumors are different. Our at least in my part of the country, the diffuse type gastric cancers, the mucinous cancers, these are more common, and most of the tumors are metastatic and advanced disease at progression. I think we get different cancers.
But Dr. Jayati, the poorly differentiated usually have a low HER2 positivity. I
Yes.
think you see. So if we are seeing more of poorly differentiated and diffuse type, then our HER2 positivity should be less. Of course, yes, they are more advanced. So HER2 negative, PDL1 positive in these cases, I think we should see them separately now. What was the morphology of the cases wherever the PDL1 is more, and usually they must be poorly differentiated because these are the ones which are more advanced.
Yes.
So, but
Look at this data now.
25% is a very big amount from the other parts of the world. So I think we should now see the Indian data. I'm going to concentrate on this
I
now.
think so. I think it's
Yes.
especially with the drug being kind of getting labeled with that, it is going to be a big clinical challenge for all of us clinicians also. So we are also trying to look at reevaluate, is it the biology, is it the tumor, is it the technique, is it the clone, is it the antibody clone? We really don't know all this, but I think all of us should kind of look at this and see if our numbers are different or not. But anyway, I think it's good all of us uniformly from all over India answered the same. So all of us are at least looking at the same way. Okay, I think we covered this question. So 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 Destiny Gastric 4. So she presented the data of Destiny Gastric 4, in which we have to do a biopsy again and document. So this trial was different because they insisted on a biopsy, documented HER2 3+, and only then enroll them into the trial. So uh, Destiny Gastric uses the HERCEP test, DACO assay, to score HER2 expression. Does this have an impact because everyone uses different types of tests? Do you think that the clone matters, and is it really very important? Dr. Sunita, you can take this.
Yes, of course. The method which you're going to be use for HER2 testing is very, very important because if it is done manually and if it is done automated, there is a lot of difference. Like we have come from manual to now automated. We use Ventana pathway 4B5, and that makes a real lot difference because it is very sensitive, very specific assay. Then whenever you have the lab derived test, one very important factor is you have to come from the pre-analytical part, like from cold ischemia time to how the specimen is going to come. Then how you are going to validate your test for the accuracy, for robustness of the test, specificity, sensitivity, everything should be looked for. Again, you have to see with for the scoring and interpretation. And I it's better to have all the SOPs written so that your colleagues should use the same. And whenever there is 1+ or 2+, and you are not very sure, it's better to discuss with your colleague and come to one conclusion and give the report. So we should not miss any of the eligible patient for the HER2 therapy. That is what I feel
Right.
when
Okay.
it is
Definitely.
considered.
Thank you. Thank you for that. Right. Dr. Vidya, HER2 2+ IHC, all of them go for ISH. Any challenges you face for ISH testing in stomach? Is it slightly different or anything?
No, not really, because we have standardized our niche reporting. So, and also the testing facility. So we have moved from fish to dish actually for these patients. And now the dish kit is also FDA approved for both gastric as well as breast cancers. And since it's a shorter turnaround time, the clinicians are more than happy, and we do see a lot of equivocal cases. We may see non-specific localization, like nuclear localization in our cases, and there could be some amount of heterogeneous staining. So the all these cases go in for fish testing, and we are quite comfortable with that. Earlier, when we were doing the fish testing, we did have problems, especially for gastric cancers, because mucin would be a very confounding factor in these cases for protein digestion for fish tests. And also signet ring cell carcinomas, it used to take a lot of effort for fish preparations. But thankfully, in the when we moved from fish to dish, we did not find that much of a variation. And in fact, things became smoother, and it is easy for the pathologist to interpret also. So in our institute, all HER2 IHC 2 plus cases go for ISH testing.
Perfect. Perfect. I think that's very important. Okay, great. I think we covered everything. I think we covered this also, the scoring and surgical samples. We covered all of this. So this was discussed also. There have been some centers from India which they spoke about 40-50%, and some which are less than 10%. And I think we did debate this, and this is for HER2, but okay, this is not the PDL1. This is the HER2 part.
I think this was earlier because we didn't have a separate scoring system for gastric, and probably there was overlap by using the breast things. But so that's why there was over reporting of the positivity is one of the point. But actually, if you only follow the gastric cancer, I'm sure the positivity should go up than breast, because gastric is any incomplete and lateral positivity is also considered positive. When you take the breast one, it has to be a complete membrane positivity. So the earlier reporting of many studies, even I had a study where I had reported almost 35 to 40%, but that was almost 12 years back. So maybe it is due to the clone or the methodology or the pre-analytical variables. I think all these have been standardized over the years, which is
Right.
also another
Yeah.
factor.
Right. Correct. Absolutely. There's a question in the chat box. I think, if any gastric carcinoma is HER2 positive on biopsy, can it be negative by the time we do it in gastric resection samples, because patients would have taken chemotherapy by then, hence making biopsy done upfront more beneficial? Yeah, a good point.
Yeah.
Yes. But if you have a positivity in the first time, yeah, so the difficulty here is, uh, if it's positive the first time and you're going for surgery, that means you have curative disease, and that's where you will really not be acting on the HER2. It's
No,
only in
and
the
one
metastatic setting where you'll
why
really be looking for HER2.
why
Yes, please.
should we even repeat?
Attempt to do this. Yeah.
Why should we repeat HER2 on the resected specimen when you have a positivity in the
Absolutely.
endoscopic biopsy and you've gone for resection? Yeah.
Absolutely. Absolutely. Both points are fully valid
But
here.
another point here, Amit,
Yeah.
when you have a resection and then you have nodal mets, then the question of repeating HER2 will come, because you want to do it on the metastatic node. Would you ask for HER2 in such instances? You have a resection specimen and you have nodal mets.
So you're saying we didn't do it the first time, and now we have a specific.
You did the first time on the endoscopic biopsy, and then you have done chemo or whatever, and then you have submitted for the resection. It's still persistent nodes with viable tumor, and it is positive. So in such instances, it becomes a metastatic disease despite chemo. So then, would you want to repeat, or it doesn't make
So
sense?
so we have not done it. That's the thing. That's the thing. We have never looked at it in 2-3 ways at the same time. So that's why the whole thought comes. Is there a heterogeneity between primary and nodes? Then I think we should do it. If there is going to be some experience with people have and say that when they did a primary and they did nodes, they found differences. Like there was some data presented earlier. I think then we will start doing it. Once, if we are seeing this heterogeneity, we should do it, because we shouldn't miss these patients. But as of now, we have never done it. We have never
Or
actually.
maybe it is that the primary endoscopic biopsy was HER2 negative, then it makes more sense to do in the resection because you have more tumor tissue available. So I think then it matters.
So the reason why this doesn't come up is anyone who has a resection is a curative disease. And if it's a
Okay.
curative disease, you're really not chasing the HER2. You just do it once because you want it in your data set that you know what it is. And if it's curative, you definitely will not be acting on it. It's only in the metastatic setting, and most metastatics wouldn't go for surgery. So that's why, though we do debate about these, but it's really, it becomes a little less important in the metastatic setting. You get one biopsy, one tissue, and that's enough for most metastatic patients. But when
Uh,
it comes to early stage treatments, like what trials are doing, and they are trying to move this up, then probably this information will become very important.
You see, I have a point here. See, when we have two biopsies of the primary and the metastatic, so like how we are doing upfront, for example, in breast cancers, we get the core needles from the axillary node as well as the breast. We put up IHCs on both. So the similar thing can be done in an upfront setting if you are getting like you have a liver mets and you're also at the same time doing the GI biopsy. So you can run the HER2. I don't think there should be an issue on that at all. So that way testing can be done. And the other thing, coming to Dr. Jaiti's question, I don't think what she is asking is wrong at all. So you if you see on the biopsy specimen, it's only cluster of 5 cells, contiguous 5 cells. So obviously when you take the percentage in your resection specimen, say that the patient has not been treated and then you're getting the resection specimen, all right? So it can be negative because you will have heterogeneity, and look at 5 cell clusters and then look at 10% of your entire section. So obviously it is going to turn negative, maybe, but you may have to run it on couple more blocks also to see actually whether it could be positive elsewhere. So that is how you need to deal with such cases.
No, I think definitely these are all learning experiences for clinicians. The whole thought is uh, clinicians have a different perspective and they don't talk. And sometimes the talk with pathologists is always less, though we keep saying we want to talk more and more. And good thing is all of us are sitting in tumor boards and discussing with each other, and that's really wonderful. And I think with this, the learning will come. I think like even this conversation today with all of you has been really wonderful for me as a learning experience for clinician. And I think we will take this forward, trying to test multiple things, understanding there is heterogeneity, and in stomach the difficulty is different. And I think it will change practice. I think definitely it will change practice.
Also,
Okay, I
one
think
point I wanted to make, sorry for interrupting.
yes.
In endoscopic biopsies, particularly if the biopsy sometimes have necrotic debris, food particle, crushed tissue, and fragments of mucosa, some of which bears tumor. Now, gastric carcinomas commonly show intestinal metaplasia in the overlying mucosa, and these metaplastic sites are known to express HER2. So it is sometimes difficult to be certain whether you are interpreting HER2 on a metaplastic epithelium or a tumor. So in those cases, I find it easier to interpret on resection if available. But I understand that the resection is essentially for a curative disease, and that HER2 is not going to get acted upon, usually, unless it progresses.
Dr. Jayanti, in this cases, what we do is when there is a crushing artifact or if there is a nuclear staining because of the intestinal metaplasia or something like that, and we are in confusion, it's better to go for fish in these cases to just to know that whether it is really HER2 positive or negative. So it is really helpful because crushing artifact, you get just background staining and you don't know what exactly is happening with it. So fish is always helpful because you might not get resection specimen, but they want to act on the disease beforehand. So fish is very helpful in these cases.
Yeah, and also dish. At least my
Yeah.
center is struggling a lot with mucinous carcinomas. So if we are trying to incorporate dish, if we can move to dish, maybe that problem would be solved.
Okay, great. Thank you very much, everyone. Thank you. It was a wonderful discussion and a good learning. Thank you. Over to the organizers.
Thank you. Thank you so much, Dr.
Thank you.
Thank you so much, sir. Thank you so much, all the panelists and sir, for making this panel discussion interesting and wonderful. It was very informative panel discussion. Thank you, everyone. Now, we have some questions from the audience. So first is targeting the
The questions have been answered, Anshika.
okay. So
We can go ahead with the next.
so our next talk is sponsored from Guardian Healthcare, and For that, we have Dr. Aparna Dha, ma'am. She's a director, Hereditary Precision Oncology and Genetic Counseling, MICC New Delhi, and she's going to speak on applications of molecular biomarkers, profiling for diagnosis and personalized treatment in gastric cancer. Over to you, ma'am.
All right. Hi, good evening, everybody. Just give me a minute. Let me share my slides. All right, can you guys see my slides?
Yes, we can. I need to make slideshow mode.
It's in slideshow mode.
Ma'am, we are only seeing half screen.
Oh,
Can you just stop the share screen and do it again?
sure. Now,
Uh, no, ma'am. Still, it's not a slideshow mode.
all right.
Aparna, you'll have to do share the full screen.
I did,
Yeah.
I did that.
The full screen.
Ma'am, just stop the share screen. Click on the share screen button. There will be a multiple windows you'll be able to see. So
Yeah,
select one will be the full screen slide and second will be not. So just select on that this thing. There will be a multiple tab once you click on the share screen.
correct.
So you so select that which is there on the full screen.
I have.
The one which says entire screen.
Yeah, I did do that. It's still
Oh.
not.
Okay.
Now?
No, ma'am.
Okay, so there's
Or
Nisar.
there'll be one more option you can do that.
yeah.
Can you just stop share? I'll tell you. Just select on the share. Just click on the application window. Entire screen will be sharing, and you can do from that.
I didn't understand. I've got the entire share.
Application. No, ma'am, it's not yet full
It's
screen.
not. Okay, hold on.
Now it is yes. Now.
Oh, it did?
Yeah, it was done. Yeah.
Now is it okay?
Yes, ma'am. Perfect.
Oh, crap. Sorry. I accidentally stopped it. Sorry. Is it okay now?
Yes, ma'am.
And it's moving, right?
Yes.
Okay, perfect. All right. After that little technical snafu, sorry about that. Good evening, everybody, and thank you so much for having me here today. And my role for today is essentially to walk you through the evolving role of molecular biomarkers, profiling and diagnosis, in the diagnosis, and personalized treatment of gastric cancers. And what we're going to be doing today is we're going to delve into the molecular taxonomy. We are going to explore actionable biomarkers. We're going to evaluate testing methodologies and understand the impact of different technologies, especially liquid biopsies, in therapy selection and disease monitoring. So this is the key outline of my talk, where we'll be talking about the genomic landscape, as I said. We'll be talking about classifications, obviously the testing methodology and sample type. And these are essentially the pillars that enable a precision oncology framework, which moves beyond empiricism into targeted biomarker-driven therapy. So let's start with our molecular classifications. So let's begin with the first one, which is the Asian Cancer Research. And this was proposed way back in 2015. And it stratified gastric cancers into 4 subtypes. You had the MSI high, which was associated with better prognosis and potential responsiveness to immunotherapy. Then you had the MSS, which was your stable, which was more the epithelial mesenchymal transitions. This was associated with poor prognosis, high recurrence, and early metastasis. And then we had those which was MSS TP53 active or MSS and TP53 inactive. These were differentiated based on their P53 mutations statuses. Now, this classification essentially correlates with the very distinct clinical behaviors and could help guide decisions regarding chemotherapy, sensitivity, and investigational agents. And then you've got now the Cancer Genome Atlas, which defined 4 molecular subtypes, and this is way back in 2014. So one was the EBV positive tumors. These were usually, these account for around 9% of your cases. These were frequently mutated with PIK3CA mutations, PDL1 overexpression, and there was somewhat a potential benefit of immune checkpoint inhibitors. In addition to this, we also saw DNA hypermethylation. You saw JAK2 amplifications. The second was the MSI high tumors. Now, this was obviously characterized by hypermutation and DNA repair deficiencies. These accounted for around 22% of your cancers. We saw high mutation burden. You saw the MLH1 promoter hypermethylation. And these were in particular enriched with mutations in genes like KRAS, PIK3CA, and your ARID1A. Then the third one was the genomically stable. This was essentially enriched for diffuse type histology, and these had RHOA mutations and cell adhesion alterations. This accounts for around 20% of your cancers. And this is somewhere where the Claudine 18 is what we tend to see under this particular subtype. And the fourth one was the chromosomal instability, often harboring receptor tyrosine kinase amplifications. Most notably, you've got your HER2, your EGFRs, your FGFR2s, and MET. And this was essentially making them candidates for targeted therapies. Now, this accounts for around 50% of your cancers, and this was usually seen in the intestinal type histology. Again, you had your TP53s also, but let's face it, TP53 seems to be everywhere. And this classification in particular is foundational for molecularly guided clinical trials and actually reflects distinct oncogenic processes. So what was the difference between these two classifications? The first one was the aim and the approach. Now, the TCGA in particular focused on a more comprehensive molecular landscape using advanced multi-platform genomic analysis, whereas the ACRG emphasized on clinical outcome predictions, relapse patterns, especially relevant to the Asian population. Second, the subtype nomenclature and overlap. So both MSIs obviously showed a very distinct favorable subtype. The TCGA's genomic stability was equivalent to the ACRG's, the MSS-EMT, which we spoke about. Both showed diffuse type histology, CDH1 alterations, and poor prognosis. The TCGA's chromosomal instability roughly splits into your MSS TP53 positive and the MSS TP53 in the ACRG, which again was differentiated by the TP53 status. In addition, it also looked at prognostic versus predictive. ACRG stratified it based on prognosis and relapse patterns. For example, is it going to be hematogenous? Is it going to versus peritoneal? TCGA provides more actionable targets and biomarkers. So let's look at the molecular landscape of gastric cancers. And I don't think there's any better diagram than to actually illustrate as to how heterogeneous, biologically heterogeneous gastric cancer is, and it's actually driven by multiple signaling pathways that regulate cell proliferation, survival, angiogenesis, and immune evasion. Now, a deeper understanding of these molecular circuits is actually one of the key reasons why we're seeing an emergence of targeted therapies and immunotherapeutic strategies in gastric cancers. So I'm going to very briefly and very quickly go over the various signaling pathways. The most important of all, the receptor tyrosine kinase. Now, here's where you see the overexpression of receptors like your EGFR, your HER2, your c-MET, which activate downstream cascades of the RAS, RAF, MAP kinase, and the PI3K, AKT-mTOR pathway, which promotes cell proliferation and survival. The MAP kinase and the ERK pathway, now this obviously acts through the EGFR HER2, then from HER2 to RAS, RAS to RAF, then to MEK, and then to ERK, which is essentially driving proliferation, invasion, and metastasis. The receptor tyrosine kinase axis is frequently activated in gastric cancers, and like I said earlier, especially in the chromosomal instability subtypes. Overexpression or amplification of the HER2, EGFR, FGFR2, your MET actually drives downstream signaling through KRAS, BRAF, and the MAP kinase cascade, which is RAF, MEK, ERK. And this promotes uncontrolled proliferation and resistance to apoptosis. Clinically, HER2 is targetable, obviously, with trastuzumab, and MET amplifications are undergoing investigation with MET inhibitors. We've got savolitinib, and there's also some studies with capmatinib and tepotinib. Now we move on to the PI3K AKT mTOR pathway. These are frequently activated again via the receptor tyrosine kinase or the PIK3CA mutations, which encourages tumor growth and resistance to apoptosis. And this is again another major axis that gets activated. Activating mutations in PIK3CA are often seen in the EBV positive and the MSI high subtypes. Now, this pathway, as we know, and I've said this before, regulates cell metabolism, proliferation, and survival, but it also contributes to immune evasion. So there are a lot of great trials that are happening over here, and I think we do know mTOR inhibitor quite often has been used as one of the targeted therapies to block this particular pathway. And then we've got the P53 and the cell cycle control. Now, inactivation of P53, TP53 is common, particularly in your chromosomal instability subtype tumors. It disrupts DNA repair and promotes genomic chaos. TP53s are, again, one of the most frequently altered genetic alterations we see across the board. And loss of P53 function essentially also impairs your cell cycle checkpoints, DNA repair, and apoptosis. So over here, while P53 is currently undruggable, yes, there are some studies with the role of using bevacizumab, not very frequently used in gastric in this particular case. But there is also some interesting data which is coming about, and there's a lot of good work happening where since P53 is currently, it's technically the downstream consequences of things like cell cycle dysregulation. So they are seeing if maybe using a CDK4/6 inhibitor is a possibility. Again, it's work in progress, a lot of good work happening there. Then we've got the WNT beta-catenin pathway, and then you've got your HGF, your c-MET. Now, these pathways essentially support your epithelial mesenchymal transitions, your EMT, invasiveness, immune evasion, and metastasis. And this pathway is particularly implicated in genomically stable and the diffuse subtype of gastric cancers. So what you'll see is mutations in the CTNNB1 or alterations in upstream regulators, which lead to the nuclear accumulation of beta-catenin and transcription, of oncogenic targets. Now, technically, we don't really have a major treatment option that is available, but it's again work in progress. You've got the c-MET HGF signaling pathway, and this is activated obviously through a MET amplification. We see point mutations, or we see HGF overexpression. Again, particularly seen in diffuse gastric type cancers. And this actually drives tumor growth, evasion, angiogenesis, and peritoneal spread. There are studies where you can use savolitinib, tepotinib, or capmatinib. And there's studies going for MET amplified or overexpressing tumors. Then we have our immune checkpoint inhibitors, your PD-1, your PD-L1. This is usually seen more in your MSI high, your EBV positive subtypes. And that's because they have a high neoantigen load, which increase immune cell infiltration and PD-L1 expression. You'll also see, because of the high neoantigen load, a high TMB. And then we've got your JAK-STAT pathways. So one thing I think which is very sure that we know about gastric cancers is progression is actually orchestrated by multiple oncogenic pathways, many of which are targeted or some of them are predictive of treatment responses. So what I've just done here is I've kind of taken all these biomarkers, put them over here into essentially a table. So we've got our agnostic markers, which is your RET fusions, your BRAF V600E, your NTRK, your MSI, and a host of others that are there. Let's not forget the Claudine 18.2 overexpression, an IHC marker, but again, a new line of treatment that is available. So the classic question, all these biomarkers, how do we test? What's our preferred sample type? So the appropriate biomarker detection actually hinges on choosing the right testing modality. So FISH is the gold standard. We heard this before also for your HER2 gene amplification. IHC provides phenotypic expressions, again, useful for HER2, PD-L1, your Claudine 18.2. And NGS over here, ideally because we're looking for fusions too, and DNA and RNA-based NGS is ideally what we look for. And obviously it gives us a beautiful picture of all the SNVs, all the somatic aberrations, and including your TMB. So looking at the bigger picture, we do look at NGS, but I think in gastric cancers with NGS, IHC cannot be ruled out. I think today that goes hand in hand. I call it precision IHC markers. It should be done together. Sample type. So, okay, you do have tissue, which will always remain the gold standard, but we sometimes do have limitations due to obviously tumor heterogeneity and invasive procurement. And then you've got liquid biopsies, your ctDNA, which offers obviously a non-invasive alternative, which captures the spatial and temporal tumor heterogeneity. So technically, the guidelines do recommend tissue testing up front, but liquid biopsy, and I'm going to show you two very interesting studies, are emerging as a vital adjunct in monitoring resistance, detecting recurrence, and actually even guiding treatment in real time. So this is just a very nice NGS report. We've seen an FGFR2 point mutation. You're seeing a PIK3CA as we discussed earlier. And what we are starting now to see is a lot of these, in this particular Guardant report, they are giving you the EBV status, the viral status. You are getting, this is a liquid biopsy report. We are looking at MSI, tumor fraction. So CGP in gastric cancers is becoming quite popular. I think this is a case some of you may recognize of a 67-year-old male. I know it's not gastric, but he had a lower GE cancer. But what was phenomenal about this case is through liquid biopsy, we actually saw the MSI status change. It went from being stable. After 2 tests, we saw it become MSI high. And I remember this particular case because it was checked and double checked and quadruple checked, because I think it was one of the first time and one of the first experiences we actually saw the MSI status change. And it was actually through liquid biopsy we detected it. The patient did relatively well on immunotherapy. Unfortunately, we did eventually lose him. So this is actually a landmark study, and I actually showed 2 liquid biopsy reports because I think we're very convinced with NGS and tissue, but when it comes to liquid biopsies, especially in gastric cancers, I thought this was something different that we could highlight. Now, for me, I think this was a landmark study that was by Dr. Shen, which was way back in 2019. And what it did, what they did was it beautifully illustrated how liquid biopsy actually tracks resistance evolution in HER2-positive gastric cancers that are treated with trastuzumab. And what they saw were that patients with innate resistance actually had a high baseline HER2 copy number and PIK3CA mutations. And what we saw was that ERBB2, ERBB4 mutations were commonly seen as acquired resistance. So ctDNA actually provided dynamic insights correlating with response and progression before imaging. And this actually underscores the potential of ctDNA not only as a diagnostic adjunct, but also as a real-time monitoring tool. Another phenomenal study, and this one was actually pretty impressive, was the Victory Umbrella trial. And it was, I think, a cornerstone in biomarker-directed gastric cancer therapy. And what they did, using clinical sequencing, patients were stratified into 8 biomarker-defined arms, each linked to a targeted therapeutic strategy. ctDNA was collected longitudinally, which showed an impressive around 89.5% concordance with tissue results. There was 100% specificity and 83.3% sensitivity. And what this trial validated was the role of plasma genotyping as a viable surrogate, especially in metastatic settings where repeat biopsies were kind of impractical. And one of the key findings from the Victory trial was the correlation between MET plasma copy number and clinical response to the drug called savolitinib, which is a selective MET TKI. So I know it's a small number, but in all 6 patients with serial plasma testing, ctDNA MET levels drop before radiographic response, making it a sensitive pharmacodynamic biomarker. And this again highlights how ctDNA actually enables real-time assessment of treatment efficacy, and it's potentially guiding continuation or switching of therapy. So if I have to sum up my slide, I think one of the key things here is, yes, gastric cancers is molecularly diverse. Yes, there's a lot of great work happening there. Is it ready for prime time? I think in a metastatic setting, we've all been pleasantly surprised with next generation sequencing and as to what kind of results it kind of throws back at us. So with gastric cancers, it is a mix of NGS and IHC just to get a full 360 view on how we should treat our patients. And on that note, I'm going to stop sharing slides and I'm happy to field any questions if required. Thank you so much.
Thank you so much, ma'am. It was wonderful talk. It was a very informative talk. And questions. So we have not received any questions from the audience till now. So audience can put their questions in the chat box. We will wait for 2 minutes. So we have not received any questions. So we will wrap up our webinar. So I would like to thank our speakers, Dr. Aparna Dhar ma'am, Dr. Shaina Dawood ma'am for giving their time. Also our moderator, Dr. Amit Ratan sir, and our panelists for making this session valuable and informative. On the behalf of AstraZeneca team, we appreciate your time and interest. Thanks to all our audience for joining today. Thank you to our sponsors, Guardian Health, for sponsoring us talk. Have a great evening ahead, everyone, and we look forward to connect again soon. Thank you, everyone, for joining.